Part 2 of diabetes. So diabetes means lots of urine. Yep, we've already talked about that. Why do people with diabetes put out lots of urine? Well, they have high blood sugar. That high blood sugar draws fluid out of the cells. The cells shrink down. That's a really important concept because they don't work as well. Especially the brain cells shrink down. So after the blood sugar gets to about 300, you'll start to see people feel a little drifty. They'll actually start to be a little bit more tired. Um, when the blood sugar gets high, you also start drawing this fluid out and it goes to the kidneys and you start peeing it out. When you start peeing it out, your body tries to rehydrate itself, so you start drinking more. So when you have high blood sugar, whether it's from diabetic ketoacidosis or the hyperosmolar hyperglycemic state, you'll get the signs of dehydration. You'll be thirsty. You'll have soft eyeballs. You'll feel weak. You'll have a rapid pulse. And your blood pressure will go down. Now, in diabetic ketoacidosis, you're not getting any insulin in the cells. So the cells actually start to go over to anaerobic and ketosis type metabolism, and they are basically burning fat. A byproduct of burning fat is hydrogen ions. And so basically you get all these ketones that are produced by this metabolism of fat, and you have higher hydrogen ions, and you basically get acidotic. And they call this ketoacidosis because it's the ketosis that really causes the acidosis. Because it's caused by diabetes, it's called diabetic ketoacidosis, or DKA. So what do? Well, the body tries to blow off carbon dioxide to raise up the pH to make you less acidic. Therefore, you get these really fast respirations called Kussmaul's respirations. Another thing you get is the ketones will be on your breath. You'll have a fruity, alcohol-like smell. These two signs are specific to diabetic ketoacidosis. You will not see either one. Now, you'll also get nausea and vomiting and decreased level of consciousness with DKA. You can get these also with the hyperosmolar state, but usually to a lesser extent. So just to review the basics, hydrogen ions plus a bicarb ion. Basically, your body is going to combine these into carbonic acid, which is H2CO3. And then that splits to water and carbon dioxide. And so you pee out the water, you blow off the carbon dioxide, and that should lower your acidity. It should lower your hydrogen ions in your body. Treatment for diabetic ketoacidosis, therefore, is to treat the dehydration, give them intravenous fluids, treat the hyperglycemia, give them insulin. If it's severe, you may need to treat the acidosis. But usually just by treating the dehydration and the hyperglycemia, you've reversed the process. They've also treated some of the acidosis themselves by the high respiratory rate. So the signs of low blood sugar, which of course is the opposite of DKA or HHS, is white, sweaty, cool skin, they're anxious, they're hungry, they're fatigued, they have a headache, their mood changes, can cause seizures, and therefore whenever somebody has a seizure, you want to make sure you do pop them and check a blood sugar, but that's not a super common phenomenon. Treatment obviously is sugar. There are medications, including glucagon, that can be given that'll mobilize sugar out of the cells, but usually if you can give them sugar, you're fine. Obviously, if they're not conscious, you'll have to give them glucagon or something else. So here's a sample case. Leroy is a 63-year-old African-American man. He's had his diabetes for about 10 years. He's 6 feet tall, he's 285, and he drives trucks. So here's the dilemma, is he really needs a DOT card. If we put him on insulin, he'll no longer be eligible for a DOT card without substantial work and often unsuccessful work. He's on glipizide, that's a sulfonylurea, likely to cause hypoglycemia. Metformin, which is a biguanide, which is to increase the resistance opposition, if you will, but mostly to stop conversion of glycogen to glucose in the liver. Januvia is a DPP4, therefore it is a medicine that is supposed to increase your circulating levels of GLP-1, and acarbose is a AGI, an alpha-glucosidase inhibitor. Unfortunately, even with all four of these, his blood sugar is still 230. Now we know that the DOT will allow him to have a little bit higher A1C than we would usually shoot for, but if he's above 9 or so, it's going to be really hard to get him a card. So what should Leroy weigh? Well, obviously he's 5 feet tall. You give him 102 points for that, or 102 pounds. Give him 7 pounds for every inch he is above 5 feet. He's 6 feet, so that's 7 times 12. Theoretically, he should be 186 pounds. Well, the problem is he's much more than that. Body mass index is 39. Most people class obesity is 30 and above is class 1, 35 and above is class 2, and 40 and above is class 3. So basically, he is at least class 2 obese. This would usually not make him eligible for weight loss surgery unless he has a comorbidity, which he does in the diabetes, so that actually would be an option. Long-term complications for the diabetes patient in type 1, which he is not, obviously, because he's not on insulin. Kidneys, eyes, and nerves, we also see these in type 2 as well. And then vascular problems definitely are an issue. This is why we check the bottom of the feet. This is why we check sensation. So what do? How do you recognize nephropathy? Basically, we want to check a microalbumin is the most sensitive thing. Blood work, of course, is going to be helpful as well. Is there a medicine that protects the kidneys? ACE inhibitors. The problem is that they can also worsen the kidneys in people with renal artery stenosis, so you do need to watch for that as well. If he's got a cough, you can put him on an ARB instead, the angiotensin receptor blocker. If his blood pressure is not very high, there are very low doses available of lisinopril. So if you'd start somebody on 10 to 20 to start them on treatment for hypertension, if they've got a normal blood pressure, you can start them on 2.5 to 5 of lisinopril. So hyperosmolar, hyperglycemic state, previously known as hyperglycemic, hyperosmolar, non-ketotic coma, various other things it's been called. So these people have a high sugar. They have a hyperosmolar state from too much glucose. They don't have fast respirations. They don't have fruity odor. They have little or no nausea and vomiting traditionally. And so basically these people can get their sugars up to 900 or 1,000 very impressively, very slow. Again, most of the symptoms are going to be pretty similar between DKA and HHS, except for the cuss malls and the sweet smelly breath.